So that leaves me to introduce Mark Duman. For those who don't know Mark, Mark is a rare breed of clinician and patient patient advocate. He is the co-founder of the Patient Information Forum, which was set up in 1997. He's been campaigning for high quality information to be fully integrated into healthcare delivery ever since. He's a non-exec director at Patient Information Forum and a director at the Healthcare Data Consultancy Monmouth Partners. We're really pleased that Mark's written the white paper with us, which is available on our website, and many of you have downloaded. And that just leaves me to hand over to Mark and allow him to talk through his slides. Mark, over to you.
Good morning or good afternoon now, thank you very much. I'm sitting on my couch in my living room looking at a sunny Salford sky, which is quite unusual. So I'm not sure where everybody else is around the globe, because these things are international. But Andrew, thank you for the opportunity both to write the paper and indeed to deliver this today. As we've talked about, you know, we're just to set some context to this. Everybody is running around knowing that not that there is a burning platform, but the platform has burnt, so there is no money anymore. And there's something here about how do we truly bring patients in as co-producers, as co-deliverers of healthcare. The policy has it very firmly in place, but as a patient and as a carer, I still see a big gap between the rhetoric of patient-centered or person-centered care and the actual practice. And I think a lot of us want to do it, but we're not quite sure how to do it. And indeed, when I ask audiences whether they themselves, as clinicians or managers, when they're put in a patient or a carer situation, and we'll talk on this later, actually exhibit the qualities we're talking about in terms of being informed and in control, usually only about a third to at the most a half of the audience actually themselves exhibit these qualities. So perhaps one of the things we need to think about off the bat is how we ourselves are, you know, living the dream in terms of our experiences of healthcare. Do we sit passively back, or are we gently coaxing the system to become a little bit more engaging? Now, I'm just going to click through. Let me just see how I do this. Now, where do I click, Andrew? Sorry to ask such a basic question, but I'm just trying to, hold on. Nope. Ah, there we go, look at that. So what are we hopefully going to get out of today? I'm just going to talk a little bit about why we're investing in this. And yes, there's a policy rhetoric, there's a moral imperative, there's an ethical imperative to involve patients and the public in what we do. But I think increasingly, given the financial climate, we also have to be able to talk to our finance managers and say, isn't just a nice thing to do, it's a clinical and indeed a financial imperative. And just as a quick caveat, when I use the term patient, with all its negativity and passivity attached to it, I'm merely using it in the context of placing somebody either in the health service or social care, or somebody who will potentially be a user of health and social care services. I well understand we could be talking about service user, citizen, consumer, etc., etc. But as a shorthand, with permission, I'm going to use the term patient. I want to talk a little bit about the evidence base for thinking of information as a therapy. I think for too long we've thought about information as leaflets, often of poor quality within medicines packaging, or leaflets on racks in hospitals on shelves. And I think we really need to begin to look at the aspect of information as a therapy in its own right, and in doing so, how we then integrate that into healthcare pathways. So next slide. Not seeming to change myself, so I'll Andrew, can you do next slide? I don't know why it's not clicking here. Nope, thank you. So this is an American slide, but I think it's important. It doesn't really matter whose fault it is. You know, in America they blame lawyers for, you know, and in this country the Medical Protection Society and insurance companies. We blame doctors for not knowing the price of things and being overly interventionalist. We can blame hospitals for pulling too many people in, etc., etc. To be blunt, it doesn't really matter who's to blame. We're, I suppose, all to blame, and we all need to fix the health system. So I'm not really into personally pointing fingers and blaming politicians and all the rest of it. We are where we are, and we just need to do the best to fix it. Next slide. So where are we? And I think this is a really key slide for us. Basically, if we look at our behaviour, it makes up 50% of our health determinants, and yet we only spend 4% on that. And this is somebody speaking who doesn't practice what they preach and had chocolate for breakfast, so there you go. What's interesting is that only 10% of actual access to healthcare services determines our healthcare, and yet we spend 90% on that. So in some respects, we have built a system that is deficit driven. It looks at disabling and not enabling our patients and our consumers and our citizens, and we focus on a model where we fix things, we don't focus on what people have. And that's a different talk. There's an awful lot of discussion now about looking at how we actually build communities who have assets, who can do things for themselves, and don't become over-reliant necessarily on an NHS or indeed any state-funded or any even private-funded system. Next slide. And I think one of the things we need to think about is what is a good NHS? And at the moment, I think at the moment a good NHS is really a big local hospital. We've seen politically, if you touch accident and emergency, if you touch maternity services, lo and behold, people start screaming, including, sadly, politicians, who perhaps I would suggest should know better. But if we again look at those health determinants versus expenditure, next slide, in a different way round, we can see that most of the incidence of care is at self-care. So about 80% of healthcare is looking after ourselves, and yet the cost of care is the other way around. And I think what we need to do is to invert both the pyramids in some respects. We need to literally have self-care at the top, where that's the one that is literally the focus of our energies, but the cost is reversed as well, in that we're not spending as much as we are in hospitals. And for that to happen, next slide, we need to literally change the way we think. And for that, oops, here we are. So for a good NHS, we have to have an engaged, an engaged healthy me. Now, that's a huge behaviour change and not something that's easy, but was touched on by Wanless, who sadly passed away. And I make a quip, which is perhaps not appropriate, that that's what happens when you do a review of the NHS. But he looked basically at the funding gap, and as we've heard, he talks about a 21 billion shortfall. Lo and behold, we have a 30 billion shortfall, of which I think 8 billion is going to be made up. So we're still looking, the figures are right, we're still looking about a 22 billion shortfall or a 30 billion shortfall in total. Next slide. Now, if you look at this, lo and behold, if you actually engage the public, and what I mean by fully engaged, that's a public who are involved in this idea of a good, healthy me, but are also involved in self-management and looking after their long-term conditions, you can make an estimated saving of £30 billion. So it's not just nice to have, it's not just rhetoric, etc., etc. There is some real financial evidence to show, and I'll show you some more up-to-date stuff, that shows that an engaged patient actually makes a difference. Now, if we look at this wonderful map of what the current NHS looks like, who knows how it's going to change? Not the easiest onion to explain or unpeel, but I think what's really important to me is, yes, people in communities are at the centre, which to me is fantastic, and it's what we want to hear. But I do challenge again that issue of rhetoric versus reality, because if you look at the key, next slide, you'll see a little bit that says providing care is that duck egg colour. Next slide. And the problem you have, just clicking here, is that that bit in the middle, which is supposed to be self-management and self-care, or those people providing care, is not coloured in that same key, that duck egg colour. Now, it's merely an omission. There's nothing in it other than somebody not having fully thought it through. But it worries me slightly that this is a map of the NHS system coming from the DH itself, and they themselves are, not explicitly, but perhaps implicitly, still suggesting a do-to model or a do-for model, not a do-with model. And I'll talk a little bit more about elements of doing with. Next slide. Now, all of you from an academic background and looking at different ways of getting patients and indeed the public citizens engaged will be familiar with Arnstein's ladder. It talks very much around 8 levels, where the lowest level is essentially manipulating patients and the public to do what you want. moving up through sort of consultation right the way up to where we have co-production and citizens very much involved in shaping things. And interestingly enough, I do some work with Leeds University and the Centre for Health Innovation there. And one of the things we were talking about was the idea of a consumer consumes what is available, whereas a citizen can actually change what the market looks like. And there's a huge fundamental difference in those thinking. So, at the moment, we are genuinely consumers of healthcare, not citizens in healthcare. We consume how the system actually provides healthcare as opposed to being able to shape healthcare services itself. And I'll touch on that very briefly later on. Another way to look at it is the patient participation ladder. So taking the same concept of Arnstein and looking at the least involvement at the bottom and the most at the top, but turning it into something that actually fits in with some of our current structures. Many of you on the call will be self-caring, so we'll have maybe taken a couple of paracetamol or ibuprofen today for a headache or for a pain. Some of you, like me, may have taken medicines in a self-management way and trying to look at my diet, etc., etc. And as we move up here from this up to the green area, you become much more nationally significant, but personally less relevant when you're involved in NICE's Citizens Panel, etc., etc. Another way to look at that is based upon some work that I'll show you in a moment that came out from NHS England in September 2013. A little heard of paper called Transforming Participation, so we moved the word yet again from involvement and engagement to participation. And we look at 3 areas, and just to give you some examples of those, next. Public engagement is very much the idea of health watch, patient participation groups, CCC, CCG, commissioning groups, lay members, all this stuff that involves the public in, as we talked earlier, about shaping things. An area where Captive Health is very much involved in and a leader in the field is the whole idea of the user experience stuff, and it's great to see healthcare catching up. And for all you some people don't like the Friends and Family test, there's a couple of benefits. One is it's really raised the profile of this idea of feedback in healthcare. And secondly, the free text field has allowed many organizations who actually have the ability to do so to interrogate that and to make some system changes. And again, there's a need to do a lot more of that and a lot better. And then the area that I particularly am interested in is around the individual participation bit. Where are we in terms of having care plans and being involved in care planning? How many of us have access to our records? How many of us being coached in a health way, etc., etc. So lots of stuff at the individual level, which is where I'm going to focus, but I will give some examples of the other. Next. So I just want to touch briefly on some cultures. I have a little personal rule that I try and digest 1 TED Talk a week. They're anything between 8 to 18 minutes long, and again, I don't know how I can see a show of hands, but can you put your hand, I don't know if I can see the hands, but maybe the organizers can. Anybody put their hands up if they're aware of TED? Maybe Andrew and Lena can let me know. Who out there's any hands gone up?
Yeah, so we have three out
so
of 8.
You can put your hands up using a little.
We have 3 out of 8 hands raised,
right?
And one's okay. Just come down. No, another, and so we've got about 37%, 40% of people saying they're aware of TED Talks right now.
Okay, so well worth looking at TED, and just literally, I do it on a Friday afternoon before I try to wind down for the weekend, although what I found is actually I'd probably better do it on a Monday when I'm full of energy, because it ends up giving me an idea and I want to do lots of things on a Friday afternoon. But talks like the one from Eric Dishman, one I just received this morning, really give you a different way to think about things and give you some much needed inspiration, especially in a UK healthcare system if our attendees are from that area of the world where sometimes, and I'm sure all systems are the same, morale gets a little bit low. So, and this one from Eric talks very much around the idea of why don't we do more team play in healthcare, with obviously the patient being very much a part of the team. Next slide. This very much is the guidance that I referred to earlier. I'm not suggesting you read all 63 pages. There is a 2-page summary. But they again use those 3 areas that I talked about in terms of public engagement, user experience, and individual participation have some great case studies which are widely applicable, and it is worth looking at. Not that I advise everybody to read lots and lots of NHS or Department of Health papers, but this is a particularly good one in terms of reframing and thinking about how we want to engage patients and the public. Next slide. Now, I think one of the problems we have is build it, they will come. And I have a slight issue in that I think we talk a lot about this patient engagement stuff, but are the patients actually ready for it? And I think some of us are and some of us aren't. And when I talk later about different activation levels, many people in the audience, when I do these talks physically, sit at the 2 or 3 level of activation as opposed to being up at level 4 where they're actively involved. I think what we need to do is to change the culture that patients are as involved in healthcare as they are in other areas of their life, as opposed to thinking that healthcare is different and we still need to follow a paternalistic model. Next slide. And that's very much evidenced by the GP patient survey. This was taken from 2013. I haven't had a chance to look at the 2014 results, but 64% of 1 million patients who were surveyed said they were involved in healthcare as much as they wanted to be, which is fantastic. That is absolutely brilliant. The problem I have is that only 3% of them actually had a care plan. And so again, we don't necessarily have those expectations, and patients think that just being involved is perhaps being a little bit too passive and not as much involvement as we would like them to have. Next slide. Rather gruesome slide before or during your lunch hour, so I'm sorry. But this was to try and, I'm a pharmacist by background. I have struggled all my life with something called the British National Formulary, which is our Bible, and it's always broken down into body systems. And when we go into hospitals and we deal with specialists, they keep talking about body parts, not about people. And I think one of the things we need to do in terms of person, people, patient-centered care is to begin to think beyond the myocardial infarction in bed 2, the liver in bed 7, etc., the person with learning disabilities. People are people, and yes, we need to categorize things in order for us to care and to treat, but I think we also need to think about the bigger whole, and that we're not just body systems. If there's any Greek scholars out there, you'll understand that Pharmacol has 2 particular meanings, and this is from the root of the Greek word, and it's about pharmaceutical, pharmacology. All the pharmacals come from that Greek word. And in front of you, you'll see a picture of an insulin prescription. And just, if you can click. Excuse me. And it has 2 meanings, the word pharmacol. One is medicine or drug, and we're all familiar with insulin. Next slide. But if you prescribe insulin, and I say this often to caregivers, and you don't think about the impact that prescribing insulin has like this on quality of life, and I think we're living in a slightly unreal world and in an overly medicalized world. Why? Because the other meaning of the word pharmaco, if we can press, is poison. And I think if we as pharmacists, as nurses, as caregivers, as managers, as pharmaceutical companies, thought a little bit more that maybe what we were giving patients was a poison that without appropriate support and information remained a poison, but with that information and support became a medicine, I think we'd spend a lot more time, resource, money, and effort on informing patients and the public about what the particular medicine they were and the support around that. Next slide. That's the idea there of information. Now, just a couple of points here about a personalized health service. You'll see that as a good Jewish boy, I use lots of pyramids in my presentations because we built them several 1,000 years ago, so it just reminds me of my ancestry. So forgive me. And I never know whether jokes in a webinar go down well or not, so you can never tell. But anyway, I make myself laugh. What we know currently about patients is their past medical history and their current medication. What we might also know, click, is their ethnicity and their communication preferences. That's not really a lot to know when we want to begin to get inside someone's health, belief system and understand their health. So I have type 2 diabetes. I was diagnosed 4 years ago. If you click, you get the quality of the images here. Hasn't come out too well. But is my diabetes a life-threatening disease, which sadly took my dad just over 5 years ago, or a touch of sugar? that my granny had, and she's still with us. You know, I think she's 125 or something ridiculous. And what also next are my medicines beliefs. So in terms of what do I believe about medicines, goes back to that point about Pharmacol. You can click, do I believe they're a miracle cure or a poison foisted on me by a disease-mongering pharmaceutical industry? Likewise, we haven't touched yet on the concept of health literacy, which isn't the same as literacy and numeracy. I can have a PhD and still not know how the health system works, and that's me being health illiterate. And even where I am health literate, into medicines, want to do something about it, I may not be motivated. Why? Last click for this. Because sometimes there's lots of issues beyond health. You know, one of my children may not be well, or may be having issues, I may be unemployed, I may have domestic issues at home, etc., etc., etc. So although we may be focused on, well, how's your HbA1c and how you're controlling your glucose and your eating, if we don't understand that whole person, never mind the body system we're treating, we'll never get to actually deliver person-centered or patient-centered healthcare. Next slide. And I think one of the key things for us to do, and I'm coming up now to a review point soon, so I will stop talking and give us all the rest, especially me, is that we don't necessarily have payers, or as we call them in the UK, commissioners, really thinking about information as first-line therapy. And I think if we were to focus on information, patient education, and self-care as a component part of healthcare delivery, it has to be delivered before and indeed alongside and during treatment. I think patients, and the evidence shows this, that patients would use services more appropriately and that they would be more engaged and more active in their own healthcare. So instead of this nice to have in terms of information, or in terms of this tick the box because it's informed consent, if we actually see information and support as a therapeutic intervention in its own right, then lo and behold, we get better financial, better experience, and indeed better clinical outcomes. And my concern is that we don't see, broadly speaking, information like that yet. And therefore I'd say that we're being a little bit negligent if we don't truly understand the patient and tailor information and support accordingly. Next slide. And again, that's just making the point of focusing there. And one of the issues we have, and this is speaking as a clinician, is I was taught to care for patients. I wasn't taught to coach patients. So when someone comes to me and says, Mark, I'm hungry, I feed them. Because to not feed them, in my definition of care and how I've been taught and educated, would be negligent. But now we need to move into an area where I'm not just saying, you're hungry, here's some food. I need to teach that patient to fish, if they so wish and if they're so able, and indeed if I'm able. And so we need to move from that caring culture in isolation to a caring and coaching culture, where I can begin to elicit patients' health beliefs, their medicines beliefs, their degree of health literacy, and begin to coach and support them to focus on what they have and to build assets from within, rather than to make them completely and utterly reliant on a system that just can't continue to afford to function, nor should it. Next slide. And I think this is a key slide for me. We need to relearn things. As clinicians, we need to relearn to coach and care. As patients, we need to be active, not passive. And as commissioners and payers of healthcare services, we need to move beyond buying and paying what we've always done and look at a much broader definition of a patient as a person and begin to look at community development, community support, and obviously information as a therapy. Next slide. So I'm not going to run this exercise because you can't do it, but it's something maybe to take back to your own particular organizations. Everybody talks about listening to patients. So what I'd suggest you do is go back to a group and at your next staff meeting or whatever it may be, ask people to pair up and to share for 1 minute their last experience of care with their partner. And that is focused on the experience. You know, how did they feel? Were they frustrated? Were they happy? What were the feelings around that? And then ask them to swap round. Right? So you'll have a 2-3 minutes once it all quietens down, and then ask people to see what, or ask people to relate what they heard and to shout out. And then ask them the following 3 questions. You can just click. Did they feel informed? Did they feel in control? And did they feedback on their experience of care? And broadly speaking, and I alluded to this earlier, about 30 to 50% of people in any audience felt informed, about 30% felt in control, and 25% often fed back on their experience of care, either good or bad. And again, reflect on your own experiences of care, because unless we change what we do, we're not going to be able to get other people to change. So I'm going to just review what we've done and then stop for a few moments. I think what we've touched on is how to move beyond policy, begin to change the culture. That we're actually a meeting of two professionals, and I often now talk about patients and staff, not patients and professionals, because I think when we say patients and professionals, it enforces that idea of them and us as opposed to us. I don't like the idea of empowerment, personally speaking, because that's about changes of balance of power and we get all distracted by that. I think it's just about partnership. As I've alluded to, we need to change the supply and demand model, so we need to get patients to be thinking of a good hospital, you know, a good NHS as not a big hospital, i.e. a supply-led model, but a good healthy me. We all need to relearn what we do, and I think all of us need to use our ears and our mouth in the proportion that we have them, 2 to 1. And with that, I'm going to stop talking and I'm going to listen.
Thank you very much, Mark. That was a really good problem statement and sets us up really well for part 2 of the talk. But before we go into that, there's 3 people with their hands up who want to speak. So we've got Nicole, Renata and Tony all wanting to speak. So I'm going to give you the floor. I'm going to do them in that order. So Nicole, you've got your hand up and you're unmuted. So over to you. Okay, so Nicole's hand has just come down and we can't hear her right now. I'm assuming that her hand was up saying she knows what a TED Talk is. Renata and Tony's hands have just come down as well. So if you do want to talk and do want to ask questions, you can do that either by asking the question in the question field or indeed by putting your hand up for the Q&A session. Mark, I have a question for you, something that came up during the course of your talk, which was around this difference between involvement, engagement and participation. You said that the narrative and the language with which we're describing this space and the DH and the structures of care describing the space seems to be constantly changing. Can you just talk us through that journey? Where has it come from? Where is it going? What's the significance of those words, please?
Yeah, well, I think we'll all look back to the time when we had HIV and breast cancer advocates very much, you know, challenging the status quo of the healthcare system and saying that things weren't good enough. And the advocacy movement, I think, grew very much from those two conditions where we had both sides were very vocal, broadly speaking, very knowledgeable, and just weren't willing to take the status quo as being acceptable. Over the time, we've had, you know, various debates about, you know, involvement is a more passive form of getting involved. You know, we start with communication, which is a transmission of material outwards and hoping that people listen. We move into an area of consultation where you're transmitting information outwards and wanting people to comment on that. And we move up to an area of co-production where, lo and behold, you're sending out, so to speak, a blank sheet of paper and saying, hi guys, we think we've got 50 million quid, we've got to look after 250,000 of you, we can't afford everything, how can we work with you to prioritise what we can pay for and what we can't pay for? And we move into citizens' juries and a whole bunch of different events that are much more collaborative and participative. I'm going to be somewhat heretical. I don't really think it matters. And the number of meetings I've been in over the last 22 years that often start off with well, a patient doesn't describe everybody, and then moves into, is it involvement, is it engagement, is it participation, doesn't bear worrying about. NHS England has used participation, but I think the word on the street is that they're now moving slightly backwards from that. And to be honest, if we just agree terms up front, I'm not really sure it matters. I'd probably stick to engagement, to be honest. But I'm sure there's some nuances in there I'm missing. But as I said, I think in terms of semantics, as long as we've agreed our terms, I think we're on a winner. My slight consternation is when we bring in new terms, like we've now got something in the UK called medicines optimization, and I find that rather frustrating because why don't we just call it making the best or making the most of your medicines? Because that would have meant what it says in the tin, and I have pleaded and begged with those up top, but sadly it's in strategy documentation, so now we need to explain what we mean. I think most people would understand the term engagement in its broadest sense, whereas participation and involvement might have slightly different nuances to them. So very long answer to say, not sure it matters as long as we're agreeing.
Thank you for that. I mean, I suppose what's interesting is that, that slide you showed with the person and the family and the patient at the center of the care, and this difference between, doing to and being done to and doing with. And I think that's the key emphasis, isn't it? And your message here is really around, we all need to relearn. We need to relearn as patients. We need to relearn as clinicians. We need to relearn as people who are caring for anyone they love who's going through a journey of care. And I suppose that brings us really nicely onto the second part of the talk, which is around how do we do that? How do we drop information into that space, and how do we help people do that better? And I've just added a handout to the session, so everybody now, if they hadn't had a chance to access it, has access to the handout, which is the new paper that Mark has written, and we've hosted. It's also available on our website. It's called 5.5 Million People for Information as Therapy. So there's a very eloquent description of the case for change, which Mark has talked us helpfully through this morning in that paper. And the second half is really about the so what. So Mark, do you want to just talk us through very briefly your 5 points in the paper, which describe what we think people can do differently and what the system and clinicians and carers need to do differently in order to change this the problem that you've described this morning?
Sure, yeah, I can do that. So I think, as we've said, there is definitely a need to look at information as a therapy. So I think that's very much the first construct. And I think a lot of people struggle with that. And we set up the Patient Information Forum back in 1997. We still exist today, thankfully. I don't know quite how we managed, to be honest, because the one issue around information as a therapy is very few people want to pay for it. We have large pharmaceutical and medical device or medical technology lobbies to pay for that side. But if we think about it, and again, I'm sadly UK focused, but any offers to work overseas, please let me know, because I'm getting fed up with the UK health system. But at least in the UK healthcare system, we're very focused on having the third sector and having charities, British Heart Foundation, Macmillan Cancer Support, Beating Bowel Cancer, Mind, etc., producing high quality information. And there's something called the information standard, and the vast majority of organizations that have taken that up are charities. And yet, my drugs, my surgery, my buildings are all paid for by the NHS. So there's something at the moment about, why am I paying twice for information as a therapy? Why am I paying my national insurance contributions to NHS and a voluntary contribution mainly to the charitable sector to produce good quality information? Surely that should be paid for, if information was a therapy, by the NHS. And I have suggested, and obviously fallen on deaf ears, except for the charity sector who love the suggestion, that the Department of Health, NHS England, should be making a contribution to these charities, because they are indeed fulfilling the NHS Constitution's idea of making sure patients are informed. So I think there's a huge issue there about recognising information as a therapy. Secondly, like any therapy, if we're looking at drugs, if we're looking at, or I should say medicines, if we're looking at surgical interventions, we want to make sure that that therapy is of the highest possible quality. And PIF, again, was born out of the fact that at least 20 odd years ago, many hospitals were producing, our consultants there were producing typed information leaflets that said, yeah, these are, of course, they're evidence-based, I'm a doctor, so they must be evidence-based. They were poorly communicated, and we began to see the blossoming of a post called a patient information manager or officer within many NHS trusts. And PIF, the Patient Information Forum, brought these guys and gals together to begin to give them a focus, some combined energy for being in a network. And from that, the Patient Information Forum has blossomed into having 500 members from the commercial, the NHS, and indeed the third stroke charitable sector, whose jobs are to produce and support the concept of good quality information for patients. I mentioned earlier that in England there is something called the Information Standard, We have in Switzerland the Health on the Net Foundation. In America we have URAC, URAC, don't ask me what it stands for, which again are various methods of accrediting information production, which is important in the context of having a quality product. So there's something out there about having a quality product. That's focused very much on how we produce information. The middle part, the third point, is integrating this into delivery. So, you know, when I was diagnosed with diabetes 4 years ago, I was handed a prescription, metformin, 500 milligrams twice a day, thank you very much, goodbye. No mention of Diabetes UK or other patient groups, no leaflets on diet, nothing at all about how I could self-manage or self-care or get access to structured patient education, which I eventually got hold of. So there's something about, you can produce great quality information, and I've already alluded to the fact that it's done mainly in the charitable sector, but how is that integrated into healthcare delivery? We've got NHS Choices, we've got patient.co.uk, but I think one of the biggest problems we're having is there's great quality stuff out there, also not so great, but it's not necessarily integrated into healthcare delivery. And as you'll have seen from the conceptual part of the talk earlier, I really strongly feel that that's negligent. If we are showing that information and support improves health outcomes, it improves finance, then why are we not integrating it into healthcare delivery? And again, it might be worth going back to your systems and saying, you know, in the same way that we have care bundles and we have different ways of looking at healthcare delivery, are we making sure that it's not just a case of informed consent and getting a patient to sign a piece of paper to make sure we're covered legislatively or legally, but actually making sure that we're doing this from a patient perspective. Penultimately, as I said earlier and focused quite a lot on, our clinicians, our staff, are often taught to do to, not to do with. We're taught to care for, not to coach our clients, our service users. And interestingly enough, we've done some work many, many years ago now where actually patients become teachers, and we're increasingly seeing things like Health Talk Online and other things where patients themselves are becoming educators and supporters to clinicians in terms of giving them a broader depth of understanding of what it's like to live with a disease. So we really need to turn things on its head and look at caring for patients and coaching them and getting clinicians to begin to think about those quality of life issues as evidenced in that picture that I showed with the young man with the insulin needles sticking out of him. And lastly, as you would expect with any intervention at all, especially in healthcare, let's measure that impact. So, you know, when we activate a patient and we move them from I'm a passive patient at level 1 up to level 4, where I'm my own advocate for healthcare, it's been shown conclusively across 7 healthcare systems by a paper from KPMG, and we can share the slides with you, the references there, that a provider organization will save between 8 to 21% of its costs by moving a patient from level 1 of being passive up to level 4 of being I'm my own advocate. And that percentage change is bigger than any other intervention that we're aware of in healthcare. It's bigger than a drug, it's bigger than a medical device. So let's measure that impact when we give patients good information and support in terms of their quality of life, in terms of clinical outcomes, and in terms of financial outcomes. Because if we don't measure it, we can't make the case for information.
Thank you for that, Mark. I find that a very, very powerful case. Could you tell us what you think some of the barriers are to people working in a different way? You're somebody who's been campaigning in this area for half of your life. You made a huge personal contribution to change in this space. Why is it so hard? What are the barriers? There's such a clear case. What's the issue here?
I just don't think we see things from other people's perspectives. We see things as, we don't see them as they are, we see them as we are. And one of the challenges I'm having to, interestingly enough, most clinicians or managers whom I've met who practice really good person-centered care have a child, have a partner, have had some direct experience of care or lack thereof, or not as good as it could be, that has changed their perspective. And this is why I go back to be a person in your job. You know, all the talks I give, I say, if there's one thing you do as a result of today and coming to this session, and that can be, you know, a 20-minute talk right the way through to full day sessions and 2-day sessions that we do with people, is do not practice medicine or do not commission healthcare services from behind your desk. Get out onto the other side, see what it's like to park as a patient, not as a consultant, and not to have that car parking space at the front of the hospital, or whatever it may be. As a commissioner or a payer of a health service, if you have not walked through that pathway, I don't believe you should be commissioning that service. And then lastly, take your personal experiences as a parent, as a carer, as a patient to work and think, how can I live the dream? How can I make sure that my patients are informed, in control, and feedback on their care? And if I don't do it, how can I expect anyone to do it? Because then I'm talking from the head, and I'm not talking from the heart. And we all know that talking from the heart, you know, really penetrates the heart. So live it, don't just talk it.
That's really helpful. So it comes back to looking in the mirror to some degree, but I mean, it strikes me as somebody who spent 10 or 15 years helping organizations go through change and working on transformation programs and so on, that you need to really systematize this stuff in order to make it work. So you've talked about integrating into healthcare delivery, you've talked about ways of putting systems around some of this work. Why is that difficult? What's the challenge there? And if people could go back to their desks and do one or two things in that space, what would you ask them to do?
Get some leadership cover. Get somebody either above you or way above you in the organization to be your leader, to be your mentor, to be your person to take flak. Because inevitably we go back to the day job. All the ideas we saw or heard on TED or in these type of webinars, hopefully, you might have taken something away, tend to pale by comparison when 1 o'clock you switch off and it's, oh my goodness me, I've got a massive to-do list. So I think first and foremost, have a clear vision of what you want to do, and that can be tiny and small, but achievable. So it's the old SMART objective, and get some air cover. Get somebody above you in the system that says, I will do my best possible way to clear any of the barriers to allow you to do this. And that could be an information prescription, it could be doing a survey to understand patient needs, it could be looking at your patient experience, your friends and family scores, and really doing something with them as opposed to just collecting them. So there's something about, what's been sitting in your desk that you never got to, what do you think could make a really big impact, are the early wins. Focus on that mission, get it measurable, and get somebody to cover you in terms of up above, get some leadership to support you. And I think with that mission and that leader, you should hopefully get, and a time frame around that, I'll give myself 3 months, hopefully you'll be able to achieve. And think small, just start small to start with. You don't need to change the entire hospital, the entire general practice, the entire local health economy. Just do something small and see and measure that benefit.
That's really helpful. Reading your paper, Mark, and I've made some comments at the end, it strikes me that, thanks in large part to the work of people like your good self, the rising information standard, and the tide that's rising in this space. There's a huge availability of really high quality information now. I think the challenge is for those of us working in healthcare to actually connect that information with the right people at the right time. I'm really proud that Captive Health can help in that area. We have some new systems now that use new technologies to do that, to create information pathways, create information journeys, assign content alongside questionnaires and any other kind of self-care information, health literature, etc., to those journeys, steps in those journeys, and get them to the right people at the right time. So it would be remiss of me not to raise that and not to make people aware that that's available, and to come back to us if you're struggling with putting systems around this stuff. Before we finish up, I'm just going to ask anybody else if they want to raise their hands and use the system to raise their hand if there are any other questions. And while you're just reflecting on that, I wanted to ask you Mark, about the person. So Mark, just thinking about patients as leaders and patients as advocates, where can we go as people who are interested in promoting the patient experience and promoting participation in terms of resources for patient participation, patient involvement, patient leadership? Can you just give us a quick reference guide and places we can go to learn more and to build the action plan that we might want to when we go back to our desks?
Yeah, I think a couple of good places to go to. So to start with some evidence and to start with some really great studies, I'd go to the Health Foundation, health.org.uk, and their two main focus is in this area. One is person-centred care, and secondly is quality, and obviously they're interlinked. So health.org.uk would be a great place to go. The King's Fund also have a patient and family-centred toolkit, which would be a very useful thing to look at. Health Talk Online gives you access to some amazing real-life stories across a number of conditions of patients living with long-term conditions and various other acute conditions, and really is used as a training tool for staff throughout. I would also be remiss if I didn't say go to the Patient Information Forum website, pifonline.org.uk. If you're a producer of information, you want to understand more about health literacy, more about evaluating your information, etc., then PIF has a whole bunch of resources. And there's loads of stuff out there, and again, happy to pull together, and I can send round later a reference list of some maybe 10 or 15 points. One paper I would circulate would be the KPMG paper, because it gives that 8 to 21% evidence figure around moving patients from being passive to active. And in this current financial climate, I think we all need hooks upon which to hang our business cases and proposals and even small ideas to do something different. So there is lots of stuff out there, and I think lastly, don't always think just about the evidence in terms of doing this alone. Get a buddy. Find somebody, a company, an organization, somebody within your organization who's done this before. There's a lot of people out there who talk the talk around person-centered care, but I think we all know the people who really walk it. And maybe go to them and say, look, you've changed renal services, you've changed wherever it may be, you've done community development work, you've really done some great stuff in your ward with your patient experience metrics. Could you help me? And people, more often than not, much as we're all busy, like nothing better than helping somebody else and mentoring and coaching somebody to emulate and indeed improve upon what they've done. So yes, read the literature, but don't be scared to reach out and in this world of webinars, actually speak to a real human being face to face.
Mark, thank you very much indeed. So I'm just going to sum up now. So your 5-point plan for affecting change in this space is: number 1, to recognize information as a therapy; number 2, to use and propagate high quality products, high quality information products using assured products and referring to kite marks. Number 3 is to integrate that into delivery effectively. Number 4 is to educate and train, and you've given us some really good pointers in terms of where we can go to find further resources on that. And number 5, to measure impact. And the big prize at the end of this is somewhere between 8 and 21% of cost savings, and there's a good strong evidence base around that you've pointed us to. Mark, thank you very, very much for your time.